Okay, so this nice paper actually delineates most of the cardiac ultrasound findings in pulmonary embolism. They mentioned about 10 signs of right ventricular strain or pressure overload or right ventricular dysfunction that you can look at in PE. Now, this is some of these can be detected by the bedside ultrasound that the internist, general internist, and not a cardiologist, when they do the bedside ultrasound or cardiac ultrasound. But, for example, these signs are actually out of the scope of POCUS, and I just brought them here to kind of for your own reference if you want to look at them, or if you're interested in cardiology and more detailed echocardiographic findings. And these findings generally, just the whole idea is that they look at like an indirect way of measuring the pressure in the pulmonary vasculature, pulmonary arterial system. For example, increase in the pulmonary artery systolic pressure can be a sign of new PE. Or they look at the right ventricular systolic function. So, for example, the tricuspid annular plane systolic excursion just looks at the movement of the tricuspid valve, which can indicate the right ventricular normal function or dysfunction. And the same for the S prime and the pulmonary artery mesosystolic notching and the 60-60 signs and the speckled tracking. Again, these are out of scope of the POCUS. I just brought them here if you are interested. This is one of the signs that I just talked about, the tricuspid annular plane systolic excursion, which basically looks at the movement of the valve leaflet of the tricuspid valve, and usually with right ventricular dysfunction there's reduce of this movement. So you can use the eyeball exam and see if this movement is really less than normal. And this is done by just looking at more and more of ultrasound, cardiac ultrasound images. But also you can be more objective and do some measurement. So again, these are kind of a representation of some of these findings, but we're going to talk about only some of them in the next slide. So some of the signs that as an internist or hospitalist or general practitioner you can try to learn to detect a PE. One is the increase in the right ventricle to left ventricular size ratio. As you know, the left ventricle is thicker and more muscular, and with increase of the pulmonary arterial pressure in pulmonary embolism, there might be like increase in the right ventricular size. This sign has a 50% sensitivity and specificity of 86%. Now, one thing to look at while you're doing the examination, and again I'm going to show you some videos, is to look at the right ventricular free wall thickness using the subcostal view. When you put the probe in the subcostal area. So basically, if the patient is having longest standing pulmonary hypertension, you expect some hypertrophy and thickness in that wall. But with pulmonary embolism, because it's relatively acute, there is no time for the muscle to hypertrophy. So there would be like a smaller thickness of the right ventricular free wall. So this is something to look at if you not sure if this increase in the right ventricular size is acute or chronic. Another sign is called the abnormal septal motion. It has a 26 sensitivity, but a specificity as high as 95%. And this is basically indicating there is increase in the right ventricular pressure, and that pressure will be transmitted into the septum to the left ventricle, and that will make the circular shaped left ventricle into a D-shaped left ventricle, as I will show you. And then the other sign is the McConnell sign. This is really very useful sign. It probably has the highest specificity, close to 97% in some study, but you're not going to see it in all the PE patients. And basically, this is just diffuse hypokinesia of the right ventricular free wall compared to the apical area. So the apex is contracting, but the other right ventricular free wall is not. So this is called McConnell sign, and there's some different explanations. We really don't know exactly why it happens, but part of this could be because of the tethering of the right ventricular apex to the left ventricle, which allow the right ventricle to pull inward by the hyperdynamic left ventricle that usually occurs in pulmonary embolism. Also, some people advocate for like ischemia to that area that makes this, right ventricular free wall not moving. But regardless, it's I think it's a very useful sign to look for. And then tricuspid regurgitation or tricuspid incompetence using the color Doppler, which most of the POCUS devices, they have the capability to do, including the one I use, which is a butterfly. Okay, so this is just an image of the increase the right ventricular ratio. So this is a normal right ventricle size. In this picture here, you see the apex is formed mostly by the left ventricle. You see the left ventricle usually is larger than the right ventricle, about 2/3. In moderate right ventricular dilation, you see like there's a enlargement of both the right ventricle and even the right atrium, and there may be some bulging into the left atrium because the pressure in the atria is less than the pressure in the ventricles in general. And this is here clearly there's more severe right ventricular enlargement, and the apex is almost all formed by the right ventricle. So this is the thickness that I talked about, the right ventricular free wall thickness. So here, the normal is expected to be less than 5 millimeters, like in this image here. This is a septum. This is a right ventricle, right atrium, left ventricle, left atrium. This is a subcostal view. This is the liver. So, this is normal compared to thickness of 9.1 millimeter in this ultrasound or subcostal view, which might indicate increased right ventricular wall thickness, and that indicate a chronic process rather than acute process. So this one goes with PE more than this one, although of course you still can develop PE on top of pulmonary hypertension for any reason. So this is regarding the first sign. This is a video of the same thing, enlargement of the right ventricular chambers. So you see again enlargement of the right ventricle. You see, especially the right atrium, I think is clearly that you see the intra-atrial septum is bulging from the right atrium to into the left atrium. So in acute setting, acute pain, shortness of breath, especially if the patient had normal heart before, this could clearly indicate a new onset pulmonary embolism. And then using the Doppler technique, then as you know, in the Doppler technique, it's just you're asking the ultrasound device to detect the motion of blood flow, any motion that's away from the probe. So the probe is here. Any motion away from the probe will be indicated by a blue color, and any movement towards the probe here will be indicated by the yellow or red color. So with tricuspid regurgitation, you expect a movement of flow to this direction, away from the probe during systole, and that's what's happening here. So you can clearly see some blue movement of blood when the valve is closed. So this indicates tricuspid regurg, and again, if this is new with the right ventricular dilatation, that can indicate a PE. And then this is abnormal septal motion, or the D sign that I talked about. So due to increased pressure in the right ventricle, there will be like more pressure on the septum, and it's supposed to be the left ventricle is supposed to be round and circular like this one here. I hope this is nicely normal, because basically this is my left ventricle. This is the one I did on myself. So you can see here it's like circular, but compared to this patient who had like a D-shaped left ventricle, indicating that increased pressure. Again, this could also be it usually indicate acute process, to be honest, but again, some patients with pulmonary hypertension, you might see this as well, but it usually indicates acute process. So this is a D sign. And McConnell sign, again, this is using the 4-chamber view, putting the probe in the apex. And you see the apex here, the right ventricular apex is actually contracting really well compared to the right ventricular free wall here, which is not really contracting that well. So contracting, not really contracting. So this is a McConnell sign. This is just another video, maybe a clearer one. You see the apex, right ventricular apex, contracting really well compared to the rest of the free right ventricular wall, which is not really contracting that well. So this is a positive McConnell sign, which has high specificity. Another sign that you are unlikely to see it because the sensitivity is really low, but it's good to be aware of it, which is the clot in transit, which is basically just finding a clot inside of the chamber, right-sided chamber, in this case the right ventricle. So you can see the clot here is actually in the right ventricle, ready to travel to the pulmonary emboli, and this is clearly an indication for TPA or thrombolytic therapy, depending on the agent that you have. And then let's click the other video here. So basically in this one you can actually see the clot again ready to embolize to the pulmonary vasculature. You see this time in right atrium. So this is called clot in transit. Again, very low sensitivity, but of course very high specificity that the patient is already having some PE or impending larger PE that can compromise their circulation. Okay, regarding the findings in lung ultrasound, it's actually kind of interesting as well. So for example, here you see this patient. This is actually one of my patients who was admitted was right-sided consolidation, found to have coccidioidomycosis or valley fever. His left side was at the beginning fine, and then he started to have left-sided chest pain. So before he developed the chest pain, we were doing lung ultrasound. We saw the consolidation obviously in the right side, but the left side was relatively okay. So you see this is the pleural line. It's thin. You see there's a lot of good normal sliding. You see this is the A line, which is a reflection of the pleural line, and this is another A line. So this is kind of a presentation of what you're seeing. So this is a pleural line, hyperechoic or white line. This one here, that's moving normally with a sliding, good sliding. And then this is the A line, which is an artifact or a reflection of the pleural line. So this looks fine, basically well aerated left side or left lung. Then after the chest pain, when we did ultrasound on him, here this is what we found. So basically it looked like he developed new B lines, and B lines are white or hyperechoic vertical lines that came all the way from the pleural line all the way to the end of the screen, and they're vertical and they move with the pleural line. So you clearly see B lines here, and stop moving. And then you see like a small triangular black area surrounded by white area, where this is where the B line is coming from. So this is kind of representation of that. So you see this small triangular area surrounded by white hyperechoic areas, and then there's a B line coming down from it. This is it's called subpleural consolidation. So this is just the same video. I'm just showing it a little bit larger here. So this is a triangular area here, and this is the pleural line coming all the way from B line. Sorry, this is the B line coming all the way from the pleural line. So this is new and this is abnormal. This triangular shaped subpleural consolidations is actually characteristic of PE. So you see that in this image here as well. This is another patient from another source, and this is another triangular subpleural consolidation also in another patient with PE. So again, these are not very specific, but they're really highly suggestive, and especially in the appropriate clinical setting with the presence of B lines, and the patient did actually have a pleuritic chest pain. So the history was kind of suggestive, although in him it was a little bit tricky because he has some history of malingering as well. We're actually trying to write this case. But yeah, this is just one of the findings that you can look at. And again, it doesn't have to be triangular all the time. It could be rounded in some patient, but usually it's triangular, just like in our patient here. And the third finding in lung ultrasound regarding PE is in some patients, especially if they have infarction, they might develop small pleural effusion. Now, remember that ultrasound is much more sensitive than chest X-ray for pleural effusion. So the especially small pleural effusions might not be seen well in chest X-ray, especially the posterior anterior or anterior posterior view. The lateral view might be a little bit better. But regardless, as you can see here, this is an ultrasound view of the lung base. So you can see the diaphragm clearly here, and then you can see diaphragm is a little bit hyperechoic or wider than this area here, which is black or anechoic. And then you see the tip of the lung here, like floating in this small amount of fluid. So this is small pleural effusion, and in the appropriate setting, if the patient is having pleuritic chest pain and there's other signs for pulmonary embolism, that could be also another supporting finding. This is just kind of a picture representing the same video. So this is again the diaphragm, this is the lung here, and you see the diaphragm moving with breathing, and then this is a small amount of pleural effusion that we can see. This is not a patient with PE, but it's kind of a representative image. All right, great. So in summary, we saw that POCUS for pulmonary embolism is actually can be quick, safe, definitely safer than CTPA, and definitely cheaper, and definitely not associated with any contrast side effect like nephropathy, anaphylaxis. There is no radiation associated with it. It has really high good specificity, especially if combined together. And it's the initial test of choice in unstable patients suspected to have pulmonary embolism. Now, the 3 exams that we talked about, or we talked about 2 of them, and the third is going to be in the separate videos. The first one is the cardiac POCUS. We talked about the 5 findings that you might look for, including the enlarged right ventricle, tricuspid regurgitation, abnormal septal motion and shaped, McConnell's sign, which has a very high specificity, and clot in transit, which has a highest specificity, of course, but unfortunately it could be really concerning. And then a lung ultrasound, you look for subpleural consolidations, you look for some B lines and small new pleural effusion. And then the third one is POCUS for DVT, and we're going to do a separate video talking about DVT, POCUS in DVT, regardless if the patient is having PE or not. So thank you all, and hopefully we'll see you in another video. Bye-bye.